Welcome to the Applied Radiology Expert Forum webinar on breast imaging, how to survive and thrive. I'm Kristen Bolin, Executive Editor of Applied Radiology, and I'll be your moderator today. The goal of today's webinar is to provide you with actionable information you can use in your clinical practice today. In this webinar, we will analyze key challenges in mammography, strategies for improving efficiency and quality, changes in the regulatory landscape, ways to maximize reimbursement, and much more. Our guest speaker today is Dr. Michael Linver, the Director of Mammography at X-Ray Associates of New Mexico and a clinical professor of radiology at the University of New Mexico School of Medicine. I'd like to take this time to thank our corporate sponsor, Sectra, for making today's webinar possible. So without further ado, let me introduce Dr. Linver. Welcome, Doctor.
Thank you, Kristen. It's a pleasure to be able to participate in this webinar today. We've got a variety of material we're going to be covering. To start off with, I want to talk about the key topics we're going to be covering. First of all, mammography key challenges, what it is we have to face here in mammography today, and then the regulatory landscape upon which we have to operate. And not only operate, but survive and hopefully thrive. Thriving and surviving have a great deal to do with our improved efficiency and quality, and digital mammography is one of the main steps that we must all undergo if we're going to achieve those levels of efficiency and quality. The workflow issues are key as well. In providing efficiency, the PACS and risk systems particularly we're going to be concentrating on and their value. Maximizing reimbursement, another critical issue for us in terms of efficiency, and we must be able to streamline the screening process to make this all effective. And last but not least, we're going to talk a little bit about the value of communicating well with our patients and with our referring physicians. The next slide we really do have good news here. The good news is terrific news. That is, mammography has changed the natural history of an entire disease. The death rate of breast cancer has dropped for over 30% in the United States since 1990, and that is almost all exclusively due to screening mammography in this country. So we have a great deal to be proud of. But the bad news is that, get the next slide to work. The bad news is that the mammography is in crisis. We are over-legislated. We are overworked. We are underpaid, by and large, for what we do. There are tremendous issues with malpractice claims against radiologists, particularly in breast imaging. They are subject to ongoing media attacks regarding the quality of mammography and this whole issue with the task force, which we'll talk a little bit more about. There are unrealistic public expectations produced by many of the media. And we are being intruded upon by other specialties as new technologies evolve regarding breast imaging. So we are at a time of crisis. And get the next slide to go. Sorry, okay, go back one. That we are in real crisis. That is, we are over-legislated, we are overworked, we are underpaid. Malpractice issues to maintain, as well as the media attacks. So crisis, though, has two meanings. That is, it means, in Chinese, it means not only danger, but also opportunity. So as we sail across the sea of success, we hope, across the mammographic maelstrom in the middle, we have an opportunity for both. We have danger and we have opportunity as crisis continues in our lives with mammography. Getting the next slide. The dangers are pretty much what I just outlined. That is, MQSA is oppressive, as well as all of the other legislation we're being subjected to. We're overworked, underpaid, subject to malpractice at a higher rate than anyone else in medicine. There are these unrealistic public and media expectations. In a word, we're subject to total mammography meltdown because of these dangers. But at the same time, as I mentioned, we have a real advantage, a real opportunity to advance what we're doing and not only survive, but thrive. And the opportunities are that we can become more efficient and create a profitable center in the process. We can use our high visibility as clinicians now with breast imaging to showcase our entire mammography practice and in essence become the face of radiology. Because our clinical role, no question, cannot be replaced by anybody else who's off-site. We can therefore prevent the wholesale loss of business to either offshore or off-site teleradiologists. This is a huge plus for what we can do with breast imaging as an opportunity. And at the same time, we have the opportunity to embrace new technologies as we expand our roles as gatekeepers and advocates for our breast cancer patients. So we are presented with both, with dangers and with opportunities. We must seize the opportunities as they present themselves. So how do we sustain our success in breast cancer screening? Screening is key. Why is this unique? Because it is really the backbone of what we do. We must do this well if the rest of breast imaging is to succeed. We must obtain high-quality mammograms. We must render high-quality interpretations. We must be able to minimize our financial losses by increasing our efficiency and reimbursement, as we're going to talk more about. And we certainly must be able to introduce any new technologies for breast cancer screening, which we know are coming down the line fast and furiously, breast MRI particularly. Tomosynthesis, a great new technology which is going to be helpful, I think, more and more in the future. Whole breast ultrasound, another whole area of tremendous value. And even molecular breast imaging may indeed prove to be useful as a screening tool for breast cancer. So we must be able to integrate these as quickly as we can as they continue to evolve if we're going to be successful in breast cancer screening. So how do we sustain our success? So the challenge is really that we need to accommodate the regulatory factors that are involved in breast cancer. And these are many, Medicare being one of them. Back in 2002, Medicare took over the fee schedule from the old congressionally mandated value, but to their credit, ACR came to our rescue and got the RUC, the RVU committee, to increase the mammography screening value for the physician work value up to 0.7 RVUs, which doesn't sound like a lot, but had a tremendous impact on our ability to survive financially. And here's some data coming up on the next slide, which shows exactly what happened in many practices as a result of the RVU adjustment. Breast imaging is the most efficient part of most practices now. This is a practice from Texas. You can see all the other specialties here did pretty well with their RVUs per day, but look at breast imaging, the one that's circled here. Tremendous, about 50% higher than anybody else. So we have this tremendous advantage if we can keep the reimbursement for breast cancer screening, for screening mammography, at a good level that it is now. So the legislation hopefully will allow us to do that. But there are tremendous changes coming. Healthcare reform is right around the corner, and even Karnak the Magnificent cannot tell us exactly what these are going to be, but believe me, they're coming fast and furiously. And here are some of the changes we're going to be seeing. The next slide is the new focus on accountability and physician performance. This is really what it's all about. Individual performance that is not currently reported under MQSA is going to be more closely scrutinized. The MOC for lifetime certificate holders, not required, but it's coming, I guarantee you. And who's going to set the metrics and thresholds and variances for all of these things and maintain that delicate balance between accuracy and access? Well, it's all these issues regarding accountability and physician performance. And we don't know exactly who's going to do this because there are so many agencies involved in the government that are now going to affect this. No question, though, it's all going to be based on value-based purchasing. This is a major initiative of CMS. They have a variety of things that they want to do, and many of them have already taken place. Accreditation requirements is now in place, as you know, and we've been the poster child in mammography ever since 1990 when the ACR mammography accreditation program began, when nobody was requiring this kind of accreditation. So we're ahead of the curve there. Pay for performance, going to no question affect us. It already has. Regarding recall rates, they're already looking at those online, and they're going to be using those to evaluate us. Physician Quality Reporting Initiative, the so-called PQR, again, is already out there, and we as breast imagers are going to be subject to that as well. And accountable care organizations. We don't know exactly where this is going to go yet, but it's part of the new legislation, and we are going to be part of that solution, whatever it is. The idea of CMS and of the other government agencies was to drive patients to the providers who can demonstrate, not just claim, but demonstrate high quality, efficient care. The hooker is, who's going to determine what is high quality? And this, for us, especially in breast imaging, is a bit of a dilemma, because we know what high quality is, and the government certainly does not. So basically, the other issue, and you're all aware of it, is the other government-driven initiative, and that is these new guidelines by the Preventive Services Task Force that came out in November of 2009, in which they very cleverly recommended no mammography whatsoever for women who are young, in their 40s, or women over the age of 74, who are no longer of any use to society, apparently, and no mammography on a yearly basis anymore for women 50 to 74. Instead, every 2 years. Don't want to give them too much, you know, in the way of an advantage over their disease. And no women should be allowed to touch their breast, no more self-examination, and nobody else should be able to touch their breasts either. So no clinical breast examination. Very clever, very, very helpful for women in this country. It's going to throw us back at least 20 years, but you know, we still have to deal with it. And has it been a factor? Absolutely, it has. As the next slide will show us here. Has it been harmful? There's no question. There's about a 20% drop nationally in mammography volume since November of 2009. Part of that, no question, was due to the economy, but I guarantee you almost all of this has been due to a direct consequence of these new guidelines. So we have a problem. We have got a lot of problems in terms of the government interference with our business. Next slide comes up here. The bottom line is many governmental agencies have a great influence on healthcare reform, on CMS, and all the changes in healthcare that are coming down the line. Radiology services, including breast imaging and intervention, are under particular scrutiny because we are thought to be specialists who are somehow grossly overpaid for what we do. So we have a real identity problem. And looking into this crystal ball, what do we see? Well, we don't see much that's good right now in terms of Obamacare. We don't know what's coming, but we don't think it's going to be too good based on all the indications so far. How is it going to affect us? We know affect us. It's not going to be great. So I advise you strongly, don't give up your day job yet, and you might even consider a night job as well. That's a little bit tongue-in-cheek, but the truth is we have some issues. We have real regulatory issues that are out there that we have to contend with. So we need to respond to this regulatory minefield. How can we respond? First, we should continue emphasis on quality and service, always putting patient care first. Don't lose sight of that. We're not a business. We're still a profession. Keep it that way always. But at the same time, we've got to assure the quality of our practice and pay for performance by doing a complete audit of our own performance to make sure we are performing at the level for which we are being held responsible. So this is a key item, and I would urge you to consider doing a complete audit, not just what's recommended by MQSA, which is almost nothing. Thirdly, we've got to maintain our reimbursement through efficiency in the workplace. We're going to talk about how ways we can maintain our efficiency, and by doing an audit of our coding and billing as well to make sure we get paid for what we do. And lastly, we need to continue to be proactive with our patients and with our clinicians in fighting those task force guidelines to try to educate and continue to advance our own specialty and maintain the high rate of breast cancer detection at an early stage that we have so far. So let's talk first about quality and service and putting the patient first. We must always put the patient first, as I mentioned. To do so, we should hone our skills in breast imaging and become a local expert. I think this is key. If you really want to do mammography well, do it well. Learn how to do it well. And purport yourself as an expert if you are indeed one. Because again, this is the way you build your practice. This is the way you maintain your edge. And you've got to do it well if you're going to say that you're doing it well. But at the same time, you have to maintain that strong relationship with your patients. Talk to your patients. Become their advocate. Learn to be by their side at every step of the way. these bonds will go so far in building your practice. And the same applies to your referring physicians. Not only be their advocates on behalf of their patients, but also give them the best service you can. Get on the phone, call the reports to them if they're positive. Keep them in the link about what's going on with their patients. This kind of personal attention cannot be replaced. It is one of the best ways to continue to allow your practice to grow and thrive, is to be a patient and a referring doctor advocate. How else can we do this? Well, the best way to do it is to be, and if you're really going to be successful as a breast imager, you've got to continue to have passion for your work and at the same time compassion for the patient. This cannot be replaced, as I said, and we should never ever lose sight of this. If we don't have these feelings in our practice for what we do, we're not going to be as successful. So what else can we do to build our efficiency in our practice and to contend against the regulatory minefield that's out there? We can assure the quality and prepare for pay for performance by doing a complete audit of our own performance as radiologists. This is key. Not only do you have to have a strong relationship with your patients and your referring docs, but you've got to be able to produce. You've got to do the work you're supposed to be doing. So how can you measure that? Well, there's a variety of ways, but we now have a wonderful way to do this. And I don't know if it's going to come up, but we're going to see. Back in 1994, I was involved in the benchmark creation for the Agency of Healthcare Policy and Research. And I don't know if this is going to come up or not. Here we go. You can see that in 1994, there were a variety of things we measured. And in 2005, we not only could have goals, but we actually had results from the Breast Cancer Consortium. The screening results actually could be measured among all the people in radiologists in this country. They measured performance in over 3 million examinations, and they measured this for positive predictive value. And this is going to come up rather slowly here, it appears. Tumors, small ones, minimal cancers, node positive cancers, cancers per thousand, recall rate, sensitivity, and cancer size. These are all things we could now measure. And when you look at the screening goals from 1994, what we were trying to achieve and what we actually have achieved in 2005, you can see they're pretty similar. In other words, the average radiologist today is doing work that's on a level with what we were hoping to achieve in 1994. So we've made great strides. At least half of the radiologists are doing the same or better than we would have thought were ideal goals in 1994. So we've come a long way. But now you have values you can compare to. You can compare your own practice to that of the screening results from the 2005 screening consortium, and see if you are up to those standards and measure your own practice against those benchmarks. So what else can we do? We can maintain adequate reimbursement through quality of efficiency. And the best way to do that initially is to get full field digital mammography. If you don't have it already, you really must get it. The costs are higher initially, but it allows for increase in patient volume and greatly decreases patient wait time, both of which make for a tremendous increase in throughput. And that's really where the rubber meets the road. You've got to be able to see patients well on a regular basis, but you've got to be able to get them through the process. And digital mammography does that like no other medium we have. At the same time, digital has many other advantages. So this is going to work. Let's see, there we go. Images can be transmitted electronically and instantly, and this has tremendous far-reaching advantages. We can compare to off-site previous studies, which we could never do before. We could do off-site diagnostic mammograms, actually, online. You can give off-site second opinions or get second opinions off-site. And lastly, even within your own department, you can communicate much quicker and much better. And just to show you as an example of this, if you see something on a mammogram and you don't know what it is, but this is what you want the technologist to evaluate, you don't have to call her back to your office. You don't even have to explain anything to her. You draw a little circle on the mammogram. If I can get this to work. And up it comes. Boom. and the tech immediately gets the answer of what she wants, what you want her to do. Immediately, no time lost whatsoever. And at the same time, once she gets these images and she's obtained the study, she can write a note, type in a note directly back to you on the PACS system to tell you exactly what she did or what she found, so that you, again, there's no lost time in communication between you and the technologist. Tremendous advantage to digital in terms of workflow. Analog workflow, what a disaster. There's at least 15 or 20 more steps that are required compared to what we do now with digital, and it does it in a very convoluted way, labor-intensive at every step. Many more people involved than we can now with digital. Digital, again, has its own issues and its own steps, as you can see here, in a digital mammography workflow basis, but they're much more direct and much less human involvement needed once the system is set up to go. And this is a big, big advantage to all of us in terms of efficiency. We must have a good electronic workflow system involving PACS and involving RIS. And speaking of which, we're going to get the next slide here. The PACS system is really the heart of any good, efficient system in any hospital now and any clinic. And if you have a small PACS system and a small department, it's not a problem. But the truth is, as we grow, we are not dealing with just one mammo unit. We are dealing with several mammo units, which must all be connected to the PACS system. And indeed, most departments have several workstations, which again present a much more complex communication problem for our overall department. And lastly, we've got other tie-ins, such as CAD, which all have to be tied in with the workstation and with the mammo unit. So, the system, the way this works, has to be done quickly and smoothly through a well-integrated PACS system, so that all of these systems communicate instantly and immediately. And you can see here, this is rather complex, but can be simplified by the use of a good PACS system. Let me get the next slide here, just to show you. This is a typical PACS system, and all of these little boxes contain issues that a good PACS system must be able to contend with, not only to get information from, but extend information to. Starting with the general workstation, which is fine to have a general workstation, but as you know, within the mammography system, you must have mammography workstations as well that are going to communicate with the PACS system. And as I mentioned, not only that, you've got to have good communication with a full field digital unit, whether it's one vendor or a different vendor. It's coming up here, or yet a third vendor, all of which must be able to communicate with a well-organized PACS system. Not only that, you have to bring in other technologies so that these can be shared and integrated into the system, not just mammography, but also ultrasound, also breast MRI, also nuclear medicine, for instance. All of these issues, they all have to be available and integrated through a well-designed PACS system. And the only way to do this is to start with a system that works well and that integrates not only with all of these items, but also with a good RIS system. They have to, in other words, your workstation must be completely filmless and paperless. And to do that, it must be capable of integrating digital mammograms, ultrasound, MRI, any interventional studies, nuclear medicine. All the reporting systems have to be tied in. The pathology reports, the clinical findings, all of these should be readily available through a good marriage of the PACS system with the RIS. And for that, you need to have a well-designed system. And we're very fortunate in our department not to look like this. This is Gillian Newstead from the University of Chicago, and she sent me this slide a couple of years ago showing what she was dealing with in her department at the University of Chicago. Here was her PACS with the workstation for the mammography, showing the images here. And right behind her, you can see that there are these non-digitized analog films still on the multi-viewer for display, totally on the other side of the room. How do you compare that with the one on the left? Very difficult. Not only that, here's her ultrasound way over here, totally different workstation. And here is her RIS system and the keyboard for that way over here. So she, as you can imagine, is not particularly happy with this situation. It is a nightmare. It is a total nightmare and absolutely unnecessary if you have a properly integrated system. Like I said, we're fortunate enough to have, with our Sectra system, a very well integrated PACS and risk system, both of which are Sectra, and it has made our lives infinitely less complicated and more comfortable. When we see images on the screen, we can immediately look at the risk information and the other information on the screen immediately next to it on the same workstation. What a pleasure. It goes as smooth as silk. And if we have other modalities, they're there too. We can bring them all up on the same screen, whether we have an MRI, or we have an ultrasound, or we have the digitized prior images, or we have the original digital mammogram. They can all be brought up side by side, same size, for easy comparison. What a pleasure. This, to me, has made my life so infinitely easier. And at the same time, I can make up my own protocols for looking at screening. Here's an example. Here you see on the screen over here, you see different images being magnified. You can do this electronically and set these protocols ahead of time using the wonderful and very easy hand control panel that's designed by Sectra. We find this tremendously valuable. I can get through a screening study in well less than a minute, very comfortably, looking at it in 4-quadrant zoom mode with the protocols that I use very, very nicely. I love it, and we've been just delighted with this system. And I must say, it has worked very well. We've had it for 3 years now, and we are still very, very pleased with it. So this is a tremendous advantage to have this kind of workflow. What we don't want, of course, is this sort of circuitous, difficult, labor-intensive kind of workflow. And to do that, you must have a good marriage of RIS and PACS. And without this kind of a marriage, you're never going to be able to achieve a good success. And we've been very fortunate in that we early on made the decision to get both the Sectra RIS and the Sectra PACS, which has made our lives much more comfortable, because if there's a problem, they can be resolved internally rather than one manufacturer, one vendor saying it's the other person's problem. We know how to resolve it because it's all within the same vendor. Of course, these machines are great, but you've got to learn how to use them properly. There is a learning curve for the human element, that is the doctors and the techs and the assistants. And not only that, there are going to be new positions that you're going to have to create in order to make this happen. You're going to need an administrator for the PACS. You're going to need a lead digital tech. And other people are going to have to change their jobs a little bit. The tech aides are going to do things differently. You're going to need a digital hanger, a digital coordinator. Medical records is going to change dramatically with the absence of film anymore. So all of these things have to be taken into account. Not only that, you have the whole issue of, it's coming up here, the fact you've got to be ready for change. You've got to educate. You've got to look at all the things you need to purchase and make the right decisions. We found it tremendously helpful to visit other Sectra sites before we made our decisions to see how well they were doing and what problems they were having, if any, and how they resolved them. And then took that back and adapted it to our own particular facility, which of course is going to be slightly different from everybody else's. But the vendors, especially the Sectra people, were very helpful in helping us construct the kind of system that we needed for our particular practice. And it's been very, very helpful to us, I must say. But just be ready for these kinds of things, because they're all part of the system. And you must have, of course, once you make your decision, you've got to build an infrastructure. You've got to have a backbone of an internal network. You've got to allow for rapid access to images. And again, that RIS-PACS connection is critical to making that happen, so you can have the kind of workflow that's going to make you as efficient as possible. And you also, of course, need to have a whole IT personnel section set up to oversee the network and keep it operating properly. There are other measures you should take to improve your efficiency and quality. I cannot urge you strongly enough to separate screening from diagnosis if you possibly can. Batch read your screening studies uninterrupted if possible. Do it at the beginning of the day, do it at the end of the day. I do it in the middle of the day, and I just don't allow any phone calls for that 1 or 2 hours when I'm in there. It works pretty well for me. I have an assistant. I'll tell you more about that in a second. I have all the cases preloaded on the workstation. I never take my eyes off the images. I go from one case to the next. I eliminate all the ambient light, And they not only help my efficiency, but I can say it's dramatically improved my interpretation skills. So this is, again, a big, big plus in terms of quality. So not only should you have your studies and look at them uninterrupted, but this slide is going to come up all the way. What's the problem here? There we go. You must utilize medical assistance to do this. I have a medical assistant. I tell her it's normal or recall, and that's all. That's all I do. Recall on the right, and she handles the rest. I never take my eyes off the film, off the images. And we try to work out a very efficient schedule for screening and diagnosis. We rarely do them on the same day in order to make us more efficient. And although the patients have to come back, they get a better interpretation if we can read in a batch form. No question about it, they're more accurate. And we also designed our breast imaging center ourselves to be ergonomic for both the patients and for our staff. And I had the opportunity to do this 11 years ago when we opened up a dedicated breast imaging center, and I've been really delighted with this. This is the floor plan for our center. When the patients come in, they come in through the front door to the registration desk, but then they're immediately triaged either to the left for screening. It's coming up here. And this is the screening section, and they have their own waiting area on that side, or to the right for diagnosis. And this is the diagnostic section where we have the diagnostic mammogram machines and the ultrasound. And again, they have their own waiting area, so we totally separate screening and diagnosis. It has made us so much more efficient. I can't even begin to tell you. If you can do that, I would urge you to do so. So what else can we do? We can audit our coding and billing. This is another way to respond to the regulatory minefield, and to do that requires a very, very simple way to maintain quality. But just to be aware of the fact that about 1/3 of your claims are being either rejected or ignored. You may not know it, but it's happening. And they, for a whole variety of reasons, the third-party payers, you know that. If you don't have the right ID, you don't have the right report that's clear and the conclusions are clear, they will deny or delay you. You must bill for what you do. You can't get paid if you don't bill. So again, if you have multiple charges, look at that. In addition, you've got to train all your personnel to look for all of the obvious things. Make sure it was ordered properly. Make sure this was pre-authorized properly. Don't overbill. Make sure there's concordance of the ICD and CPT codes. Don't upgrade inappropriately. That's going to backfire. But most importantly, perform an internal data quality audit. Look for mistakes that are being made that are going to result in denial or delay. And there's a variety of these. And as you know, the insurance companies don't look too far to find something they can criticize so they don't have to pay you right away. Either incorrect procedure, pre-authorization is not obtained, incorrect ICD or CPT code, wrong report was dictated or incomplete, inadequate written documentation, incorrect billing information. Any of these things are going to ding you for and slow down your reimbursement or stop it altogether. If you're not aware of it, you're going to be in trouble. Another great thing to do when you audit your practice is do a monthly evaluation of the main benchmarks, the important benchmarks that tell you how you're getting paid. The total charges, are they going up or down? Your collections, the number of days that a claim is remaining in the accounts receivable. If they're remaining too long in accounts receivable, you've got to do something about it. The distribution of the accounts receivable, is it changing dramatically from one month to the next? And your payer mix. All of these things can be a reflection of a problem that you cannot otherwise identify that's delaying or denying you the reimbursement to which you're entitled. So these are all easy things to do if you have a system in place to do it. The other and the final piece to maintaining a way to respond to the legislative issues, it's coming up here, I hope soon. The next slide. Next slide not coming up. Get a little help here. There we go. Okay, so we have to be proactive in with patients and clinicians in fighting the task force screening guidelines. The guidelines, you know them well, only too well, that these are totally preposterous. They're going to result, according to Ed Hendrick, when he analyzed the data, if every woman went by these guidelines, approximately 6,500 more women will die every year going forward if people follow these guidelines instead of the guidelines that you and I know are the ones they should be following, and those are those of the American Cancer Society. That is, a woman of average risk should be getting a mammogram every year beginning at 40, that she should begin clinical breast examination. What happened there? Okay, we got to go forward again. Every 3 years beginning at 40, and she should undergo breast self-examination on a regular basis. These we know will work. They work for us. That's why the death rate is down at least 30% in the United States, and it's down 60% in Sweden. You know, unbelievable. And for older women, we know that we must continue annual screening after the age of 74 for those who are in reasonably good health and a candidate for treatment, because on the average, these women are going to live another 20 to 25 years. So we owe them the right to maintain their health at a maximum level by finding breast cancer early, even in this group. So what is the problem? The problem is education. We have to let patients know the true facts. We have to let the referring docs know the true facts. If we do nothing and say nothing, it's as though we are giving our tacit approval to these truly murderous manifestos. We owe it to our patients to stand up and do the right thing and say the right thing. And I've tried to do this from the beginning. What we did in our practice is we sent letters to about 60,000 of our patients. It's a one-page letter. It lists all of the key points, why we think the task force was wrong, what the data are really that show that they were wrong, the data that they refused to evaluate, like the screening programs that showed a 40% decrease in death rate in 10 different countries, which they threw out. And I used the data from our own practice. As you can see here, we diagnosed, 766 cancers since 2007, and 25% were in women under age 50. I think those are key data to show to your patients that we're doing the job, and if we can only do it on the basis of the American Cancer Society terms and not those of the task force recommendations. Here's the rest of the letter. Not only that, we sent out a letter to all of our referring physicians. This letter is slightly different from the one we sent to our patients, worded slightly differently, but some of the same information in a little more sophisticated way. And again, a one-page letter can't be longer than a page, and I think it's incumbent upon you to educate your patients, educate your referring docs, make sure they know that what you're doing is in the best interest of their patients and is truly going to save their patients' lives. And I think this is the key. You must be part of the solution and not part of the problem. And on that basis, I would be happy to supply you with a copy of these letters, or I have a whole PowerPoint talk that I have about the screening guidelines you can show to your medical staffs or whoever, lay groups as well. Just contact me on my email address at mammomike@aol.com. And again, I thank you very much for your attention. This was a very quick review of a lot of critical issues, but hopefully there was something in there that you found some value. And if you have other questions, we're going to have a question and answer period that's going to begin here momentarily.